Hi, everybody. This is another portion of chapter 38. We did the nitrous oxide separately. This is the local anesthesia chapter. We're going to be discussing the injectable and non-injectable modalities. Now, local anesthesia is one of the main modalities for the management of dental pain, and it can actually block sensations, especially pain, from the teeth, the soft tissues, the bone in the area that's being anesthetized. So we, as clinicians, are doing root instrumentation. And it's important for us to do that without discomfort, because that way we can get in and do what we need to do for our patients and not have to worry about them being sensitive and us being timid with our instrumentation techniques. So what are some of the potential hazards for occupational exposure? We can have a needle stick, and that's one of the main occupational hazards that we have. So we need to learn best practices, which is one of the reasons why, as a dental hygiene student, you will not be allowed to set up the tray, to set up the cartridge and the syringe, or tear it down in the sterilization area and handle the sharps until you have the skill evaluations for those particular techniques. So we are going to teach you best practices. So let's talk just a little bit about the pharmacology of local anesthetics. We have what we call a dental cartridge. Now, layman's terms or general dental term is carpule. But carpule is a name brand of a cartridge, just like Kleenex is a name brand of facial tissues. So we want to use proper terminology. Cavitron is a name brand. We use the proper term is ultrasonic, right? So a dental cartridge is really pre-filled from the manufacturer, and cartridges are either 1.7 or 1.8 milliliters, and that's going to become important when you start having to deal with the math. And we're not going to deal with math here in DNH 142. But you've got amide anesthetics, and you need to know the difference between amide and esters for the sake of this course. And the amide anesthetic blocks the transfer of ions across the nerve membrane, which then stops the transmission of pain messages. Inside the cartridge, besides the amide anesthetic, you oftentimes have vasoconstrictors, and that constricts the blood vessels to offset the vasodilation that's caused by the amide anesthetic. So the amide anesthetic is going to vasodilate. Vasoconstrictors are put in there, epinephrine being the main one, to vasoconstrict, and that provides a greater duration of anesthetic and more profound anesthesia of the anesthetic, as well as hemostasis for that immediate area that's being anesthetized. So know what the vasoconstrictors are used for. There's antioxidants in the cartridges, and those are preservatives to prevent oxidation of the vasoconstrictor. It's usually sodium metabobisulfite or sodium bisulfite. Okay, know those terms. You've got sterile water, which is a diluting agent, and sodium chloride, which creates a biocompatible solution with the body. So you've got ester and amide anesthetic drugs, and the drug is divided chemically into those two categories. The first anesthetic was Procaine or Novocaine, and that was an ester, which has not been available in the United States since 1996. Now, when patients come in and say they are allergic to Novocaine, you have to then ask further questions. When were they diagnosed as being allergic, and also what symptoms did they have? It's just like codeine allergies. I'm allergic to codeine. Well, why? What symptoms did you have? Well, it upset my stomach. Well, that's a natural reaction to the codeine, so it's not an allergic reaction. But these medications are eliminated through the kidneys, And so you have to make sure that the patient has good kidney function as well as liver function. So let's talk a little bit about amides. All right, that causes vasodilation of the blood vessels. There is less allergic reaction to the amide than there is to the ester, and it's metabolized by the liver, and it's eliminated through the kidneys. So the duration of amide drugs, there's three categories. You've got short acting, long acting, and intermediate acting. I should have said short, intermediate, and long acting. And you want to match the anesthetic to the procedure that you're performing in the office, as well as what the postoperative discomfort might be for the patient. So the individual will respond to medications like anything else individually. So the type of injection being administered will affect also the amount of anesthetic that the patient feels, as well as the operator technique. How precise are you in the placement of that anesthetic? And then there's anatomical barriers. I mean, the ligaments and tendons and facial planes and the density of the bone all has to do with that as well. The vascularity at the injection site, right? How fast is that anesthetic going to be able to diffuse into the tissues? And the presence of inflammation or infection, because that changes if they've got inflammation or infection. It changes the pH, which will also alter the amount of absorption of the anesthetic that the patient will experience. So if the patient has what we call a hot tooth, if it's an infected tooth, it's very difficult to get that patient comfortable. So what are some of the specific characteristics of amides? We've got lidocaine. Okay, that is a brand name of xylocaine, and it's usually considered intermediate acting, and the lidocaine is the gold standard of all the local anesthetics. It's metabolized in the liver, excreted by the kidneys, as most everything is. The concentration is 2%. So it's got a vasoconstrictor in it, which is used for hemostasis, and it's usually 1 to 100,000. Okay, the cartridges are either, as I said, 1.8 milliliters or 1.7 milliliters. So everything used to be 1.8. And then with the latex allergies that were becoming so prevalent, the stopper in the cartridge was made out of latex. When they went to non-latex silicone stoppers, they were a little bit larger than what the latex ones were, so the cartridges contain just a little bit less of the solution. Now for FDA, Food and Drug Administration pregnancy category, it's category B, and we're going to have a box on that. So what you're going to be learning in your anesthetic course is calculating the maximum recommended dose, right? We're not going to worry about that, okay? Absolute contraindications are patients that are allergic to local anesthetic or the sodium bisulfite. And if anybody is taking cocaine or methamphetamine within the previous 24 hours, that is contraindicated for any local anesthetic. Relative contraindications are cardiovascular disease, angina, hypertension, hyperthyroidism, and of course the liver and kidney disease. Patients taking beta blockers and steroid dependent patients, sometimes asthmatics as well, would be contraindicated because of the lidocaine in there, the epinephrine that is in that lidocaine hydrochloride. So it's recommended for, you can use it on pediatric patients. It is safe for pregnant women for most procedures, and it has an intermediate action. Then you've got the mepivacaine, and that is carbocaine. Okay, and that is a short acting, and we use carbocaine plain It's a 3% solution. It has a very weak vasodilator. Again, this is metabolized in the liver and excreted by the kidneys, right? That's the take home that. And the concentration's 2% or 3% plain. The clinic has 3% plain. Now that does not have the vasoconstrictor in it. So you can choose plain or something with that acts a little bit longer, that has the epinephrine in it. That is a FDA pregnancy category C. So that's about all I want you to know about that. Then you also have something called Prilocaine, or the brand name is Citinest, and that is a short-acting that's administered as an infiltration, or an intermediate acting that's administered as a nerve block. But that, again, has a weak vasodilator in it, and that concentration is 4%. It does have epinephrine in it. That is a pregnancy category B, and it's excreted just like everything else. Now, with the Citinest, you have to be careful of something called the methylmeglobinemia, okay, which you've heard about, right? And that is something that has to do where it's a condition that reduces the blood's oxygen carrying capacity. So that's one of the medical contraindications. Absolute contraindication, again, is allergy to the local anesthetic or the sodium bisulfite, as well as cocaine or methamphetamine use within the last 24 hours. Relative contraindications, significant liver or kidney disease, methylmeglobinemia, sickle cell anemia, respiratory or cardiac failure in patients on acetaminophen long term. Now that's because of the liver damage that could be resulting with that. But it's that's that. Then we've got Articaine, and that's an intermediate. It has a short half-life, so it gets dissipated through the body fairly rapidly. It's a pregnancy category C. And the absolute contraindication is standard, and if they're allergic to sodium bisulfite, and again, cocaine and methamphetamine use within the previous 24 hours. So you're seeing a scenario with this that is similar to all the anesthetics. Then you've got bupivacaine, which is what name brand is Marcaine, and that's the longest onset. So that is the most potent of the local anesthesias. It is pregnancy category C. Marcaine is a long acting. So what happens with that is the patient might be getting a different anesthetic during the procedure, but then the dentist would inject Marcaine following, before the patient leaves, to give them, say, a 6 to 8 hour window of anesthetic. So by that time, the ibuprofen or whatever the oral analgesics they are prescribed or recommended can then kick in. So we've got vasoconstrictors that are added, and we like them because of longer duration, less bleeding, that type of thing. And it also is more effective for them. So we will match the anesthetic according to what the patient's medical history and the procedure is. There is, on Dentrix, there is a request that you have to fill out for the DDS to approve. And at that time, what the dentist will do is look at the patient's medical history and look at the perio charting, seeing what you want to do. Most of the times they agree with what you're asking. Sometimes they will say, no, I don't want this anesthetic used. I'd prefer you to use carbocaine because of something else and, that they're seeing or that they're concerned of. So we have to be aware of that. In private practice, you are making those decisions. So some of the preservatives that are in them, we've got the sodium bisulfate, and that is a preservative. It prevents oxidation of the vasoconstrictor, and that provides a longer shelf life, so they do have expiration dates. We use the expired cartridges when you are learning how to hook up the anesthetic syringes, and when you are injecting into the plum and other things. We don't need to use the good stuff for that. You've got epinephrine that we've talked about. And I think that's about what you need to know when it comes for that. So we've got our pregnancy categories. A, which is safe for everybody because it hasn't shown any risks in animals. Category B, animal reproduction studies have failed to demonstrate a risk to the fetus, okay? But we don't have any good, well-controlled studies on humans, obviously. And then pregnancy category C does show adverse effects, and D and X we are staying away from. So what are some of the indications for local anesthesia? You know what the indications are. You want to be able to do what you need to do for your patient as quickly and as effectively as possible. So sometimes they require this. Anesthetic prevents both the patient and the clinician from the anticipation of discomfort. So you can get in and do what you need to do without having to worry about the patient. Levitating off the chair. So for dental hygiene procedures, it's scaling and root planing in the areas of probing depths more than 4 millimeters. That doesn't mean if you've got a patient with 5 millimeter probing depths that you need to use anesthetic. It is dependent on the patient. You'll have some patients that you can't even probe effectively, even though they're not a difficult patient as far as the amount of calculus. They're just so hypersensitive that you need to do it quadrant by quadrant. But extensive instrumentation with either manual or power driven instruments, your ultrasonic or piezos, whatever, sometimes will dictate that the patient will be more comfortable with some sort of anesthetic. Right? Treatment, think about the topography of furcations and tight tissue. How much manipulation of the tissue are you going to be? How sensitive are those root surfaces? How inflamed is the soft tissue? Do you need to do any gingival curettage or suture removal? Are you removing overhanging restorations that does require manipulation of the tissue? So all of that, and of course the patient's preference. Some patients will want to be anesthetized. Some will withstand anything to avoid the needle. So you're doing your assessment, and just like you are on everybody. And the goal of the assessment is to ensure that an effective and safe local anesthetic experience is being performed. So your pre-treatment evaluation is the first and most important step in avoiding a medical emergency. So you're looking at the chief complaint, you've taken the vital signs, your ASA, you're doing everything. Okay, what's the patient's emotional status? What's their dental history? Have they had local anesthesia before, and how have they reacted to it? Did it take for them? Some patients will say that, oh, I'm always difficult to numb. So that might be an indication of the type of anesthetic that you're recommending for your patient. And is there infection or inflammation that's present that would make it more difficult for the patient to get numb? So the amide local anesthetics and the vasoconstrictors are normally incorporated into the dental cartridge. You want to avoid the use of local anesthetic or specific local anesthetics because of certain high medical risks, blood pressure issues, thyroid issues, those type of things. You can also think of alternative drugs that might minimize or avoid the risk. You want to limit the dose of the drug being given. So you don't want to, for example, anesthetize 2 quadrants thinking you're going to do 2 quadrants, and then something happens and you only get to complete 1 quadrant and you don't even get to start the other quadrant. You then just injected more medication than what the patient required. So you want to use also the local anesthetic in combination with stress reduction techniques. So you are sometimes using nitrous oxide during the injection process. You might need to seek medical intervention or a medical consult. But you administer a block or regional injections rather than infiltration in the inflamed tissue, because that inflamed tissue has a low pH that inhibits the drug distribution as well as the effectiveness. So that is just one of those asides to keep in the back of your head, because you are going to be utilizing that tidbit of information when you get into local anesthetics. What are some of the general medical considerations? Regular utilization of safeguards are going to be paramount. That's your medical history, your dialogue with the patient, your vitals that you're taking and that type of stuff, your ASA classification. Now, ASA 3 and 4, you might not be seeing 4s in the office, but ASA 3s sometimes come into the office and they're very anxious about injections. Oftentimes they are unstable with something, be it thyroid or blood pressure, so you want to be careful with your amount, especially with epinephrine. So when you're performing a risk-benefit analysis, you're not writing any of this down, but you're thinking about it. You might need a medical consult. You are calculating the maximum recommended dose for the patients. Now, in Virginia, we do have local anesthesia that hygienists can do, but they have to be 18 years. The patients need to be 18 years or older. So we're not administering to children. They have slightly different anatomy and, of course, different needs as far as the amount of anesthetic. So we are saying, for the purposes of the book, we want adult patients to be weighing at least 150 pounds, because under 150 pounds, you've got to really be more cognizant of how much is too much, because we want to administer the smallest amount possible. All right, let's talk now a little bit about the amide and ester anesthetics. Amide anesthetics, true allergy is rare, but if it's confirmed, you want to avoid using that drug at all costs because of a chance of having an allergic reaction. Now, esters is more common for allergies, and if it's confirmed, you want to avoid ester anesthetics, especially topical anesthetics. And as we said earlier, we are not finding injectables in the United States of ester anymore, but there are topicals. Bisulfite allergies, okay, that is the preservative. You want to avoid using anything with vasoconstrictors if they're allergic to bisulfites because of that allergy. So the best choice for that is to use a plain anesthetic, anything without vasoconstriction there. There's something called malignant hyperthermia, and that's a life-threatening complication associated with the administration of general anesthetics. Now, we're not dealing with that in our general practice, but if you're working in a perio office or an oral surgeon's office, somebody that does a lot of implants, for example, they might be using other types of sedation, even hospital dentistry. So you need to be aware of that. And then there's also a condition, methylmegaloglobulinaria. How do you like that for mispronunciation? And that's a congenital or acquired condition where the hemoglobin molecules converted into methylmeglobulin, which has, again, less oxygen carrying capacity. So the patient is going to not be able to get oxygen to where they need to get. So take a look at some of the medical considerations. It does take some common sense if you think about it for what some of the contraindications might be, as well as some of the specific medical considerations for diabetes. Epinephrine has been shown to oppose the action of insulin, but not a whole lot. So you want to make sure that the patient who's diabetic is a controlled diabetic, and did they eat today? What was their blood glucose, right? Glaucoma, which is pressure in the eye. You want to avoid vasoconstriction. You want to avoid anything that might have a drug interaction. So that could be, again, think about the cocaine or methamphetamine within the last 24 hours. Do they have liver disease or kidney disease? Are they on some sort of antidepressant, which could increase the risk of hypertension? Are they on other medications like Thorazine, where vasoconstrictors could create a severe hypotension? So this is one reason why we want you to have drug cards out for each and every medication that the patient is taking, so you can make sure that there aren't any of these contraindications that you need to be aware of. So what's some of the armamentarium of local anesthetic? Now, this is something that you can get on your own, because you're not hooking everything up, you're not putting it together. But you can go to the sterilization area, wherever the local anesthesia card is, or however your school has it categorized, and you can get the syringe and the needle and the cartridge or the carpule. Okay, we call them cartridges, and any additional armamentarium that you might need. Cotton tip applicators, topical anesthetic, that type of thing. And we'll be talking about the sequence very briefly. Now, we went into a lot about the different types of anesthetic, which I'm not expecting you to know for this chapter. Just know that some have epinephrine and some do not. Some are short, intermediate, or long acting. Okay, that's the takeaway for this. But look at the color coding. This is the color coding for the United States. And some of these colors are stand out, like the red. Okay, is the standard lidocaine 2% with epinephrine. That's what we said the gold standard was, the red. But if you take a look and things are all jumbled up in a drawer, take a look at the mepivacaine plain. That's a gold, okay, or a brownish, and compare that to the articaine. Look at the articaine, which is the gold, and compare that to the prilocaine with epinephrine. So you have to look at what you're using and what you're taking to administer to the patient. So it's the rule of thumb is to always look at things 3 times. You're looking at it when you're taking it out and getting it ready. You're looking at it before you hook up your syringe, and you're looking at it again before you administer the anesthetic, okay, just to make sure there are no mistakes. So we have different types of needles. It's long, short, and they've got a mini short in there too. They come in millimeters. So we've got different parts of the needle. They are single use. We also have safety syringes. Let me see if okay, this is a safety syringe. It's a self-sheathing safety needle, where you can see that this is the cover here, and then you use it. Okay, the cover goes down, and as soon as you're done, it's sheathed again. So you don't have to worry about how to take care of the needle for a possible exposure there. But you want to be able to, when you're putting the cartridge in the syringe, you want to be able to make sure that you can see what you're placing, okay, just for verification. The needles are long or short, okay. The long is about 1 inch, the short is less, and then they also have extra short. So depending on what you're trying to inject and where you're trying to inject, okay, you need it to be able to reach where you're trying to go. So offices will usually just have long or short or long or extra short. They don't have the combination of all of them. And they are color-coded according to their gauge. Now, the gauge is the needle diameter. And for this, it's how big is that hole where the anesthetic comes out. So they're ranked from largest to smallest. So 25 gauge is the largest lumen. Then it's got 27 and 30 gauge. So 25 is the largest, which means the needle is less flexible, versus the 30 gauge has the thinnest lumen and it's very flexible. So for the rigidity, 25 gauge needles are stiffer and have less needle deflection as it passes through the tissue. So you have more accuracy of where the needle is going to end up with deep tissue penetration. So we like using the thicker gauge, the 25 gauge needle, when we're going through a lot of tissue. Think about trying to get things into that cheek area, all right? If it's too thin, if the needle's too thin and flexible, it wobbles as you're trying to insert it into the tissue, and heaven only knows where you end up. So 25 or 30 gauge are the both extremes, 25, 27, and 30. And personal preference will oftentimes dictate what the office has. The cartridges or carpules, 1.7, 1.8 milliliters. We're only using 1.7 milliliters in the United States because we don't have the latex stopper. And we looked over the colors. We want an aspirating syringe. They have a little, sometimes they'll have a ring for your thumb to go through, because once you inject and you think you've found the area that you want to inject, you pull back on the needle a little bit to bring an air bubble or something into the cartridge so you can make sure you're not in a blood vessel. And that's what the aspirating syringes are all about. So you aspirate. And then when you know you've got a negative aspiration, there's no blood coming in, then you can inject. And there's also the sharps management that we're going to be getting into, because we don't want any exposures. That's the authorization to test that the patient needs to sign before we even get past the medical history. So what are some of the techniques here? Okay, depending on where you're trying to inject, you don't need to learn this, okay, for this semester, but you can see the different colors on the different types of anesthesia. And the nice thing is you've had head and neck anatomy, so you're not having to learn any new landmarks. The ASA, anterior superior alveolar. The MSA, middle superior alveolar. PSA, posterior superior alveolar. So you can see that the names are just like you learned them, but you'll be getting more into this a little bit, okay? They do have, instead of injecting manually, they have computer-controlled anesthesia, which some offices have, and that is a very light pen-like handpiece that's attached to a computer-controlled device. It goes very slow and controlled, and patients love it because it is as painless as an anesthetic injection can be. So we looked at the self-sheathing. This is some of the armamentarium that most offices will have. They'll either have something similar to the blue, which you put the cap in, and the cap sticks straight up, and then you can put the needle into the cap. We at the MEC have these paper barriers, but you need hemostat or cotton forceps to be able to take things apart. We don't want you using your fingers whenever possible, all right? Because when you use your fingers, you have the potential of getting an exposure. So your non-dominant hand is never touching the thing where you're trying to place the needle. You always have that standing by itself, and you'll be placing it just with one hand and locking it in. And then we will be teaching you the proper way to be able to handle your sharps. Okay, so until you've got that skill evaluation down in your local anesthesia course, your instructor will be doing this for you. Now, there are some adverse reactions to local anesthesia. One of them can be overdose, and that's why you are learning calculations, because there is a toxicity level that can happen. Now, after your boards, you really don't need to worry about that so much. When I was taking my local anesthesia, it was well beyond dental hygiene school, and we needed to learn the math, but the takeaway was, if you have to give more than 8 cartridges to anybody, that's too much. Give up. So instead of worrying about how much the maximum dose is. Now that again is going to be different if they've got heart issues and other things going on, but you don't want to overdose. You want to make sure that you're aspirating, so you're not putting this medication directly into the circulatory system. You want to make sure that they've got good liver and kidney function. We don't need to worry about, as clinicians, pediatric population, but with peds, you only want to treat 1 quadrant at a time. Pediatric patients are very, dentists are cautious about the local anesthetic that they administer, because the patient will oftentimes be creating injury to themselves. They'll be biting their lip or biting their tongue. So with kids, you are much more conservative. You want to also limit the amount of topical anesthetic you're using. When I was a dental assistant, I would just scoop up a bunch of topical and swab it all over the place, because I didn't know where the dentist was injecting. I had a good idea up in the vestibule, for example, but I just smeared it all over the place. And that's really overdosing the patient, and you can have some tissue reaction to that as well. So you're just placing a small amount of anesthetic where you need to apply it. We're not rubbing it in, because we don't want this to abrade the tissue, or we don't want to burn the tissue in any way. And excuse me, we want to make sure that the topical is on there long enough, but not too long, because again, the patient can have a reaction to it. So the psychogenic reactions oftentimes come with the fear of the dental needle. We can allay the fear, but have the patient close their eyes. We're talking to them in a calm manner. You're going to feel a slight pinch. We're not telling them, that this is going to hurt, but it's because with the topical, it really shouldn't, unless you're doing a palatal injection. We're putting your hand on their shoulder, saying, you're doing great. Those are those psychogenic things that we can do to calm the patient. But when there's a patient that is very fearful, they've got that white knuckle syndrome, they're going to feel everything. They're squinting and they're levitating off the chair. You need to really help calm them, right? The pinch is going to be exaggerated with this type of patient because of the anticipation, as well as they might be more difficult to anesthetize. The local complications could be a burn from or an allergic reaction due to the topical. It could be, especially if the topical is on for too long. As an assistant, you put the topical on, wait for the doctor to come in to do the anesthesia, but they get stuck in another room for whatever reason, and that Q-tip or those Q-tips are in the patient's mouth for 15 minutes or so. That's just too long. So there could be a localized hypersensitivity to the topical anesthetic. They could also get a hematoma or a bruise where the injection site is. Responses can be very mild also, and they can be more severe if the injection is into a blood vessel and not soft tissue. So we want to use best practice, all right? Another complication is paresthesia. The book lists that under local complications. Now, paresthesia is when you sometimes will nick the nerve. We don't want to inject into the nerve. We want to inject around the nerve, and then it diffuses, the anesthetic diffuses into the nerve to create the anesthetic. But sometimes we'll bruise the nerve, and they can have paresthesia, a little bit of numbness, which oftentimes will dissipate. There's also trismus that can occur, where the patient has a problem opening their mouth wide after a while, because think about how far we're injecting that needle. So what are some of the advantages of local anesthesia? Well, when the patient's experiencing no pain or discomfort during treatment, we can do what we need to do. We can go in with increased confidence, and we can do it with minimal downtime, because we can go in and get out, like ripping the Band-Aid off. So ideally, we want to be able to work as efficiently as possible. We want to have a complete reversal of the anesthetic without side effects. We'd like to have something that's rapid onset, relatively free of side effects, as well as achieving hemostasis, so there's not a lot of bleeding when we're doing our procedures. Some of the disadvantages, again, is the patient anticipating and receiving the injection. This is the number one thing that the public talks about with fear of dentistry. What do you hate most about going to the dentist? And it's usually receiving an injection. So we need to use anxiety reducing techniques, okay, those psychogenic reactions. The patient can also get claustrophobic. They are unaware that the epinephrine will increase their heart rate, so they start getting heart palpitations, and that panics them because they think they're having a heart attack. So it's important that we stay with the patient at all times. And there's also the potential for soft tissue injury, that the patient can't feel themselves, so they're biting themselves. It's a little tingly, the feeling's coming back, so they're gnawing on their tongue or their cheek. So they need to be cautious about that until all of their sensations come back. So let's talk a little bit now about the non-injectable anesthesias. We have them available in the clinic. Offices will have them as well. Offices will have a variety of things available, and some offices will just have one brand or one type, just to keep inventory simple. So the first one is Orachix that we're going to talk about. And you have an Orachix applicator that was part of your first year kit. Orachix is a combination of lidocaine and prilocaine. Okay, this is a topical anesthetic. It's 2.5 lidocaine, 2.5 prilocaine, and it's a subgingival liquid to gel delivery system. So you have this cartridge that has the combination of the prilocaine and lidocaine in it. You place it in here. It's got a cannula that you bend, and then this little lever here gets pushed down to make it drip. So you place this drop right at the gingival margin. It stays for about 30 seconds to anesthetize the gingival margin. Then you can place it into the deeper pocket area. And it lasts for maybe 20 minutes. Usual is about 14 to 30 minutes. Takes about a minute for it to have onset. So this is good if you've got multiple sites or quadrants that you're treating, and it anesthetizes the gum tissue, okay, the gingival sulcus or the pocket. The maximum dose is 5 cartridges. I've never seen a student really need more than 1, even for full mouth. Contraindicated for patients allergic to amides or a history of methylglobulomania, and for children, because it's not approved for children. So you've got this unique dispenser here. And when you are writing up your notes, there's not a template for this, but you're going to be saying that you you used or placed Orachix, then in parentheses 2.5 Lido, 2.5 Prilo, because you're listing the ingredients, a half a cartridge, upper right quadrant, you know, and did it work or not? Because you always want to know if it worked or not, and no adverse reactions. So have this sterile, you know, and available to you in case you need it. You need instructor approval to get it, because usually they're someplace else in the office, but or in the clinic. But and there is one skill evaluation that you need to do before you graduate. So we'll walk you through this. It's the hardest thing is hooking it up. It's very simple to use. Then we've got our anesthetic gels. And that can be applied directly to the surface of the mucous membrane. We use the topical gels prior to injection. What you can also do is have just a little bit on a dappen dish, a disposable dappen dish, and place your curette toe into the anesthetic and then place that into the pocket area to give you a localized topical anesthetic subgingivally. There are a lot of different ones available. And we're going to be getting into those. So again, depending on what your office has, but this is for short duration. It does reduce the discomfort during an injection. It gives you temporary relief from localized diseased areas like aphthous ulcers, or if you can't stretch something and you're trying to examine it. Sometimes topical can be used also prior to suture removal. But you don't want to rub it into the tissue. It's very superficial anesthesia, but it's absorbed through the tissue. So you don't want to apply too much to it. And the absorption depends on the thickness of the tissue and the degree of keratinization. So think about what tissues are going to be resistant to topical application. Okay, your skin, your lips, your palatal mucosa that's keratinized. Okay, very slow absorption. Versus the faster absorption is tissue that doesn't have keratinized tissue in it. So that's your vestibule. So there's certain different formulations. One of them is benzocaine, and that is down on the lower left of the slide here. And that's an ester. Now remember that esters, patients can be allergic to. We don't have that in cartridges anymore. It's usually 20%, so we'd say we have 20% we apply 20% benzocaine topical, but it comes in a gel and a spray and patches, those type of things. The onset's about 30 seconds to 2 minutes. The duration is about 5 to 15 minutes. It's not readily absorbed into the circulation, so the toxicity level is minimal, but we again want to be careful of the amount that we're giving to the patient. All right, the nice thing with the esters, the hurricane, and the benzocaine is it comes in a lot of different flavors. So you can even ask the patient, would you prefer banana or mint or cherry or pina colada? It's kind of like the fluoride flavors. Then we have the lidocaine, which is also available in a topical, and that's that center picture. This is what the MEC has here, 5% lidocaine, 4% lidocaine is available over the counter. So those are those topical gels for sore muscles and things that the patient can get. We've got 5% lidocaine. It tastes awful, but it's very effective. Again, it can come in at 2%. We've got the 5%. A little bit goes a long way. Toxicity is unlikely. So it's very popular. Another one is diclone, which I have used. It's a liquid that right now the pharmacy can, what am I trying to say, formulate it for you. And I used to have the patient swish with that, and oh my gosh, was that ever effective. But diclonine or diclone is also in Sucrets and Cepacol lozenges. It comes in spray as well for sore throats. And that could be good for taking radiographs. We have other tinctures that could be made up as well. And Cetacane is one of them that we have. It comes in a liquid and it comes in a spray. We have the spray for radiology. Most offices don't have that. Hospitals do, and G-tubes, those type of things, because it is a profound topical anesthetic that's good for the throat, but it's really great for severe gaggers. Tastes awful. Cetacane comes in a topical where you press down on this little lid area here and you get a little topical gel. Cetacane is a liquid that you can get syringes and a little disposable plastic cannula, which is great for squirting underneath the gum tissues. Now, this is a combination of 3 different anesthetics. So when you are getting ready to write up your notes, you're going to say you use Cetacane topical liquid, for example, and then you're going to need to look at the label to say it was 2% tetracaine, 2% butamin, and 14% benzocaine. So you need to list, just like the Orachix, what the ingredients were. So for topical anesthetic, there's quite a few applications that you can choose from. You want to make sure that the patient isn't allergic. You're going to dry the area off with a 2x2. You're going to put a little bit of topical on the cotton tip applicator and just apply it directly to where you need to. Right, the same thing with the Orachix and the Cetacane gel. If you're using that, is you're drying the tissue off first, okay, and just applying it to where you need, and only apply it as much as you need. They even have new things out on the market. There is an anesthesia reversal agent that is that's available. Dental hygienists in Virginia are not allowed to use this. It's called Oraverse, and it's a non-selective alpha adrenogenic blocking agent. You don't need to know that, but they do have things that can reverse the anesthesia. The DDS has to do that. That's nice for patients undergoing surgery, oral surgery, and those type of things that have to go back into work or give a presentation, that type of thing. And think about also, they're using it for general anesthesia as well. It brings us right out of the general anesthesia. They also have an intranasal dental anesthetic that come in various types of administration systems, and that is for maxillary injections. So you don't even need to be injecting. They have anesthetic buffering systems where they you need to be careful of the expiration date for that, but it doesn't burn as much when the anesthetic is being administered. So like anything else, you're going to document everything. We do have templates for your documentation, except for the topical, but you're going to list the number of cartridges, the type and concentration in milligrams. You are going to also always document how the patient reacted. Now for nitrous oxide, there's a template for that too. But you are going to talk to the patient about why you are recommending things for nitrous. Adult patients can eat normally. Kids, you tell them not to eat before they come in because they just like to throw up for some reason. So again, you're telling the patient what they need to do and why you're asking them to do that. Local anesthetics, oftentimes you have written post-operative instructions, not only for the anesthesia, but for whatever the procedure it is that you're performing. So that's that on local anesthesia.